Hello, everyone. Thank you for joining us here at Stanford Medicine for our Building a Culture of Health Equity monthly series. We are so excited to be with you here today. My name is Magali Faciotto, and I am Associate Dean for the Office of Faculty Development and Diversity here at Stanford Medicine. The program today is organized by Stanford Medicine's Office on Continuing Medical Education, the Stanford Medicine Health Equity Action Leadership, or HEAL, Faculty Network, and the Stanford Medicine REACH Initiative. I have a couple of Zoom housekeeping items before we begin. So if you have any technical questions during the webinar, please use the Zoom chat function and the webinar host will respond. We do want this to be an interactive session, one in which we learn from our expert speakers as well as from one another. So we invite you to use the Q&A button if you'd like to submit a question to our speakers. Feel free to add your question at any point of the lecture, and we will do our best to get to them during the Q&A segment. Now, to view our previously recorded Building a Culture of Health Equity webinars, you can visit healthequity.stanford.edu. Today's event will feature a presentation by Dr. Purna Kushalnagar and Claire Ryan, joined by two ASL interpreters, Linda Jo and Charette Estes. The presentation will be followed by an open Q&A, as I mentioned, in a fireside chat format. We'll be recording the presentation today, and we will notify registrants once the recording is posted online. Again, feel free to submit questions via the Q&A feature, and we will get to those after the initial presentations. Now I'll take a moment to introduce our presenters for today. Purna Kushalnagar, PhD, is the principal investigator of multi-million grants funded by the National Institutes of Health that support studies aligned with her research interest, patient-centered outcomes, cancer health communication, and applied interventions to reduce deaf health disparities. She is also a professor and chief research officer at Gallaudet University. Claire Ryan is a doctoral candidate at the University of Texas at Austin, specializing in pediatric psychology. She has clinical training in providing evidence-based assessment and intervention to youth and their family in schools, medical settings, and mental health treatment centers. Claire's research interests center around identifying risk factors and increasing the capacity for early screening and identification to improve behavioral health outcomes for deaf youth. So thank you, Dr. Kushalnagar and Claire.
And thank you for inviting us to be here. I am Purna, and I will let Claire introduce herself, but I am really excited to be here. Claire, would you like to introduce yourself?
Hi there, I'm Claire, and I'm excited to be here as well. I'm going to go ahead and share my screen with the slides for today's program.
Great.
Excellent. I'm hoping everyone can see us now.
All right, if we can go ahead and go to the next slide, please. I want to explain first why I selected this picture. Can everyone see this? In the front, the child is deaf and is essentially not knowing what's happening behind them. And what's happening behind them is this child's family interacting and enjoying themselves. I want you to think about this picture. This picture is a real indication. The author is deaf and was trying to denote her childhood experience that she had repeatedly growing up, that feeling of feeling left out and neglected. And so we're going to be talking about that experience throughout our presentation and how that impacts a child's health outcomes and what we can do to prevent it. And so we're calling that adverse childhood communication experiences and how we can reduce those risk factors in adulthood. Next slide. By the end of our presentation today, you as the audience should be able to define what the ACCE means, to be able to identify the constructs within AACE. There are two, and we will explain those later today. And then to be able to explain how severe AACE ACCEs impact adults and their medical conditions. There are particular medical conditions that our research shows that have a real connection with their communication outcomes, communication experiences in childhood. And so what we're doing in the Center for Deaf Health Equity, the center started in 2015. It was funded by the National Institute of Health. And at that time, when we received funding, there wasn't much research actively happening around certain groups of people within the deaf population. And at that time, we knew that deaf people in general are facing disparities when you compare it to the general population as it relates to health literacy, health management, access to health information, using the internet to find health information and to be able to make decisions about their health. We knew that in general that there are disparities. That said, I felt at that time that simply knowing that there was disparities wasn't enough. We needed to better understand which subgroups within the population are being more adversely impacted. Knowing that allows for us to develop a program that works for those particular subgroups and using particular interventions. So first, we divided the deaf population where we were looking at specifically throughout the US and collecting data and using the patient reported outcomes measurements. So we gave that survey. It was available in written English and sign language. We provided it in a bilingual format. That allowed for us to collect and analyze data to identify gaps within the deaf community with their health disparities. When we identified the health disparities, we were able to put rough numbers together. We brought those numbers to our community of deaf patients and providers to get their perspective on what those numbers mean and why those numbers are happening and what's happening within the medical system to impact these numbers. We then together created solutions to reduce the health disparities. So today our focus is on ACCEs. Claire, next slide.
Right. So we know there is information about a variety of countries, but we do want to talk about exactly what it looks like for deaf children and that population here in the United States of America. We find that 90% of those children are born to parents who can hear. And typically, those parents have never experienced having exposure to a deaf person, having met a deaf person before. And there are unique communication needs. You know, the first time they meet a deaf person is their own child. And we find that most hearing parents then choose to try to use spoken language with their deaf children. And a very small percent, I would say, would integrate the use of sign language as well. But understandably, the larger percentage of that group of folks are not fluent in their communication with their deaf child. So there is a communication barrier that they experience in their own home and with their own family, and that is quite common. So we can talk more about what those communication experiences look like and what the impact of those are on the development of those children. And what we have found is that there may be some harmful assumptions being made in relation to deaf children. And those assumptions can be conscious or unconscious, but they definitely influence the patient care that's received, the medical context, and ongoing work in identifying and addressing harmful assumptions. The first harmful assumption is that we expect deaf children to show language deprivation. We believe that that language delay is something that's normal. This assumption leads to many practitioners and family members and others seeing a child who has language delays and thinking, oh, well, this child is deaf. It makes sense. And we just accept it. The fact that they're deaf means language delay automatically. And that belief itself is false and it's very harmful. Because at that point, it becomes normalized to just accept that that's where that child is because they're deaf. But the research has definitely shown that it's not a lack of auditory access that causes these language delays, but is a lack of access to language and a lack of access to exposure to communication, whether that's a spoken language or a sign language. So it's a lack of access to a very strong, robust um, ability to access communication during the critical ages of 0 to 5. And this is something that impacts them then for the rest of their life. So there is a psychiatrist at the Boston Hospital, Sanjay, and Dr. Sanjay has noticed that this is something that's very common among deaf parents, deaf children. They have this social emotional impact, and that's related to the lack of access to language exposure during childhood. And what that might look like is something that Dr. Sanjay labeled as language deprivation. And he talked about what that pattern looks like, that they struggle with concepts of time, with understanding cause and effect. For example, perhaps a deaf child is walking along and they fall and they hurt themselves. Perhaps they scrape their knee and they cry about it for a while. Their mom comes, helps them, comforts them, soothes them, and they feel better. Well, with language, you can understand, oh, I fell, I hurt my knee, and then my mother came and she helped me, she took care of me, and then I felt better. But without having a language foundation, that understanding is completely missing. Being able to link it, being able to understand the context, being able to understand the sequence of actions. So it definitely impacts that child. Now, the next harmful assumption that is often made is that spoken language should be prioritized over sign language. And that belief in itself is called linguicism. And research has shown that sign language is a language, a language that is equivalent to any spoken language. Sign languages can provide deaf children with full visual access to the world. So this medical studies that have been done, again, shows that most deaf children are born to parents who can hear, and they always choose spoken language over sign languages, instead of choosing both, because of the idea that if they don't successfully develop spoken language, then they won't have access to language. But they're missing a critical period of language acquisition when sign language acquisition should be prioritized. And so that language deprivation then prevents them from developing a language completely. And then the last harmful assumption I'd like to focus on is the fact that because children are deaf, they will normally feel isolated and have social difficulties just because they are deaf. And again, this assumption that, oh, they're deaf, we just have to accept the fact that they feel isolated. And really, it's the environment, that there is lack of access to communication within their environment that causes this feeling of rejection and isolation and feeling left out. And many deaf people have shared their stories about this, saying that they did feel left out. They didn't have access within the environment where they were placed. It wasn't a fully accessible environment, for example, an environment where they were always communicated with in sign language, where they were able to develop language appropriately. So this assumption is like, oh, they're deaf. It's okay. No, we need to address these things and realize that deaf children have the same right. They deserve the same access to being able to express their fundamental needs in sign language, in a language in which they can communicate, just as hearing children do. Sorry about that. There we go. So the next point for us as practitioners and those who work in a medical setting, we think about our core ethical foundation: do no harm. Do no harm. And what that means is the ability to predict, the ability to think about predictors of harm, things that could cause harm, and address them, work to prevent them or minimize any potential harm that could be caused. So that means that medical providers, are in a huge position of power. They have an education, they work with their colleagues and their families, they work with deaf and hard of hearing children, and they need to educate them about harmful assumptions that could impact their patient care. And so we share that information with them about how these particular experiences can then impact health outcomes in order to work to minimize that impact and to reduce that health disparity for deaf children. So now I'm wondering for the members of the audience, when you see this statement, adverse childhood experiences, what comes to mind for you? Have you seen that term before, and what comes to mind for you? If you can go ahead and put your comments in the chat, appreciate it.
Jolinda, I believe you may be on mute.
I'm sorry. We're recognizing more and more that what happens with these adverse childhood experiences definitely affects the outcome of their health. And so when we share with deaf children in the classroom, often we separate them from other children. I see that being mentioned. I saw trauma, I saw divorce, I saw a variety of different things in the chat. So I want to talk more with you about what exactly adverse childhood experiences is. And I want to talk about the concept of trauma and toxic stress and how toxic stress impacts us. There are different types of stress. The first one is positive stress. And that's something that happens normally in our development, where you have a brief period of increases in your heart rate, mild elevations in your stress hormone levels. For example, the first day of school for children, when they're going to a new school, they're nervous and they don't know what to expect. That's positive stress response. It happens for a brief period of time and it's a normal situation. The next level of toxic stress or stress is called tolerable stress. And this is the type of stress where it's more serious, you could say. It's a temporary stress response, and it can happen in a protective environment. It's buffered by those protective environments, supportive individuals in protective environments, and it's still something that's short term. It's not ongoing. So it might be a child who experiences illness or injury, but they have a good support system. They have their family with them who can support them in that situation and to help them to cope with the stress that they're facing. So the stress level is tolerable. Now, the last level of stress is one that is called toxic stress. And that's something that is prolonged, chronic. It's a chronic activation of the stress response system in your body. And so you're experiencing an event and you feel that things are out of control. You don't have enough support to deal with things within your environment. And that causes this ongoing stress that eventually impacts health outcomes. So ACEs, these adverse childhood experiences, are considered toxic stress. So with this slide, we see here how the experience of adverse childhood experiences will impact the body in different ways. And these are the experiences like many of you shared in the chat. It can be an experience of physical abuse. It can be emotional abuse or neglect. It could be sexual abuse. It could be the death of a parent. It could be illness of a parent. It could be, abuse in the family. It could be a variety of different things, bullying. And all of these are beyond a child's capacity to control. And so studies identified the experiences and show that the impact of adverse childhood experiences later on in life, in terms of things like diabetes and heart disease, and other situations that could lead to early death, as shown here on the slide. And it definitely impacts their health outcomes. All right, and now I'll move on to this particular picture. And I do want to ask you, what do you see in the slide? What do you see happening here? Someone said exclusion. Someone said they see an isolated child. Isolation. So someone said a person feeling confused about being isolated. Definitely. So this picture actually shows what it's like for a deaf child and not knowing what's going on. And that feeling of being confused, that feeling of being isolated, of being with people, but then lacking communication access, and not feeling that connection with them anymore, not feeling that they've been included because they don't have that access to communication. So in this situation, they do feel rejected or isolated. Okay.
All right, thank you, Claire. And so through my center, we came up with some new findings, some serious impacts on poor health outcomes. So first, let me explain how this happens. It's very concerning, and I will go into detail about how this happens. Next slide, please. To briefly review the literature, up until not long ago, there has been a clear connection between language deprivation syndrome and communication neglect and mental health outcomes. The connection is clear between that and psychiatric disorders. But there was a lot of speculation that it could impact the health, but there was no data, no research to show a true connection between adverse childhood communication experiences and certain chronic health conditions. Next slide, please. So my research team defines ACCEs that it's the individual's perception of feelings of being left out consistently or often ignored or excluded from family conversations. We are not talking about the occasional situation where you don't understand or you miss information. We are talking about children who constantly feel ignored because they cannot understand or constantly not able to understand what their caregivers are saying and vice versa. Many parents have the best of intentions. They always do. Parents love their children. They want to include them. That said, the experience of language deprivation happens. Communication neglect happens. So that phenomena has to be acknowledged and named. Once we name what that is and recognize that it falls on a spectrum, then providers can develop appropriate screening plans to have early detection, interventions with the family to improve communication relationships with their children. Next slide, please. What you see here, this quote, "Are you real?" These are real quotes. These are common experiences that deaf, blind, and hard of hearing children who are now adults will share. When they get together and they reflect on their childhood, these are the quotes that we see come up in conversation. And so we're looking at this child in the picture and they're wondering, why is everyone laughing? And so they ask an adult, they ask their sibling, what are they talking about? I'm really curious. But the family members may say, oh, it's not very important, or I'll tell you later. Or don't interrupt me when I'm talking because it's not polite. That creates more confusion for the child who is deaf, blind, or hard of hearing. And again, it's not the family's intention to ignore the child, but this is what's happening to many, many deaf children, regardless of where they live, here in the US, in Canada, in India, South America, and the world over. It happens everywhere. So it's very important for the healthcare provider who has frequent contact with these young children. It's very important for the provider to collect this information, ask these screening questions to be able to capture the sense if this child is experiencing that, and work with the family to create an inclusive communication environment for the child. Next slide, please. So they're asking for Charette to turn off her video so they can see me fully. How's that? So our work, this data, is based on patient-reported outcomes. It was given in a bilingual environment online and in one-on-one interviews conducted virtually. We did over 1,500 of these interviews, and we collected this information from a group of people who were able to take these surveys. This population was randomly self-selected, relatively, and these are people there are people who we have recruited via way of mouth. What we found is of that sample size, 11% had little to no access to language at home when they were growing up. So 11% might seem small on its surface, but these are people who can participate in the survey, who do have the ability to answer these questions. So we excluded many, many other people who are experiencing language deprivation to an extreme degree that it impacts their cognitive abilities, like Claire mentioned. So this number could be higher if we were able to conduct this interview the world over to all deaf people. Of the sample, 40% of these individuals said that they have language and they are able to understand if conversations are happening one-on-one. But in a group setting, 39% of these individuals said they would often or always feel excluded if they were participating in group conversation. 40% is a very high number. And that's the number that I want us to pay attention to. Oftentimes, we pay attention to the obviously impacted, people who are obviously language deprived and how it's impacting them on a mental health level. But we forget those people who have language but still experience this neglect. We are looking at a number of 40%, and I'm going to talk about why on the next slide. So first, if a deaf individual as an adult reflects that they could never understood what their parent was saying, and the parent could never truly understand what their child was saying, that repeated experience of not being able to understand each other is connected to higher risk of things like diabetes, heart conditions, hypertension, and other chronic illnesses. Another finding, the 40% figure that I mentioned earlier, is what we see here. People who have experienced feeling left out or ignored from family conversations frequently, consistently are prone to feeling things like lung disease, depression, anxiety disorder. This aligns with the literature that we've seen happen. Dr. Sanjay Gutli coined the term LDS, language deprivation syndrome. And he is a renowned physician who has worked with lots of mental health patients who are deaf, blind, and hard of hearing. And he mentioned that in his clinical practice, what he saw matches the data that we found. And basically that is people who missed language access growing up. We call that experiencing language deprivation. And that often impacts their health literacy, their health management abilities, and ultimately impacts chronic disease because they're not able to ultimately take care of themselves health-wise. So the first finding is a more physical finding, but the second one is a more of an emotional finding. The emotional aspect of this is if they know they're missing the information, it is an emotional impact. That impacts them and their mental health. These two require two different types of interventions. Next slide. The evidence that I'm sharing with you all is something that we believe is a constant struggle to understand, right? So if people are constantly struggling to understand what's happening on an individual conversation or in a group, that's impacting or triggering the child's toxic stress response system. That decreases their ability to regulate their emotions, to cope, and that could explain the increased risk to health outcomes later on in life. And this is regards to what I was mentioning earlier. Direct ACCEs and how that ties into language deprivation. And we've focused a lot about language deprivation so far, but we do want to focus on other people who have language, but experience communication neglect and what happens to those adults. And so we have some suggestions that I will share and some tips on how to work with that population and their families. There are plenty of suggestions on how to approach this dilemma. We are proposing several solutions to alleviate or diminish the ACC's experiences. One is that the family has to have language in order for the child to have language. So both the parents and the child need to be exposed to a visual language, sign language, for example, immediately after birth. They also need to be exposed to a written and spoken language. And so for the US, that could be English, it could be Spanish, it could be whatever language that's being used in the home. So at birth, the child needs to start having exposure to a written, spoken, and signed language. That allows for this child to then develop the tools to participate and understand and express how they feel when conversing with their family. The family also needs to take a moment to notice that this child is maybe feeling left out and take a moment to pause and explain to their deaf child what's going on in any given environment. They should not be using phrases like, "I'll tell you later." Those phrases are very harmful to deaf children who are simply very curious. They want to connect and engage with their family members. They're excited to belong. So when they hear phrases like that, like "I'll tell you later," or "It's not important," that's what makes them feel excluded and then left out. To support both approaches, there has to be a state mandate that every deaf child has to be exposed to sign language and other languages that that particular culture or society uses. That would help to prevent language deprivation and those harmful outcomes on chronic diseases. Another solution for you all, if you're a provider in the healthcare setting and working with deaf children, you can work to develop a screening tool. And that could be 2 questions, perhaps 3, that focus on language deprivation or communication neglect in your well checkup with your children who come on an annual basis. A trained deaf mentor can also help these hearing family members effectively communicate with their children. It could include visual technology to support that communication by way of captions, signing avatars, speech recognition software. Those things can help promote communication facilitation between the family member and the deaf child. Next slide. And I'll pass it back over to Claire.
Yes, and related to what Dr. Kushalkner was just speaking to, I do want to talk about these well child checkups, these wellness visits. You are right there on the front line working with deaf children, so take a minute to check on that. What does their communication really look like? And I would also take that opportunity to educate the family, to educate the parents, so that they really understand that with deaf children, often, when we think about what are our best options for deaf children to communicate, in my experience, in my clinical practice, I had the opportunity to work with deaf children who had experienced language deprivation. With several years of having the spoken language training, having being a cochlear implant from maybe since the time they were 3 or 4, and maybe knew just 5 words instead of the 500 words that they should know. And in relation to that experience, having medical providers who the parents really do respect. They listen to medical providers and what they say. So we have the power to educate parents and say, you know what? It's important to include a sign language because we want your child to have access to language right away while they're in speech therapy, while they're developing their speech skills, so that they can communicate with their family. There's so many providers who say, well, no, don't let them use a sign language because that will interrupt their ability to learn speech. That is so not true. Having speech as a foundation or having sign language as a foundation is going to help them to be bilingual, trilingual, etc. So it's definitely helpful. So medical providers can start that conversation and emphasize the importance of a visual language and how important it's going to be for that child. Not just to value speech, but to value sign languages as well. And then to educate parents about communication, not to put the burden of communication on the deaf child, but the entire family needs to adjust their communication strategies so that everyone has access and can communicate, can share what their basic needs are for food and shelter. Um, in a child's development, they need communication, they need a language. And that's considered a basic need. Often we take it for granted for children who can hear. Another practice strategy that can be done when you're trying to focus on deaf health equity, whether we're talking about children or adults, if they have this common experience of being excluded from the conversation, they really value access to information. So when they grow up, if their environment was not fully accessible and maybe with their primary caregiver, they felt left out and they missed so much information in family communication. They missed information about health. They missed learning about the family's health history. They missed information such as cancer screenings. So there's a lot of information that they missed along the way. As a medical provider, take the time. I know you're very busy and you're seeing a lot of patients. But just take time to ensure that you explain health information to them, review that with your deaf patient, and make sure that they really understand what's going on. And this can be done when you have access to them through their medical appointment. Ask them what their preference is, also in terms of communication. Maybe they prefer to have an interpreter, maybe they want to write notes back and forth. Everyone has different preferences. So everyone from the front desk all the way to the doctor should ask about this communication access and make sure they're fully getting the benefits of this health visit and that they're fully gathering the information that they need in order to be able to take care of their health. You also want to provide access that is what we call deaf friendly in terms of the resources. You can have a deaf mentor for hearing parents who have deaf children who are concerned about how they provide this full access in a sign language way for their children. Connect them with mentors who are deaf from your community who can help teach them and show them how to use visual strategies to make sure that their child is fully included in conversations. The clinician and medical providers who are familiar and working with deaf children, maybe they are deaf themselves, can also provide information. So share with your colleagues and with parents and families. So there are a variety of ways that you can increase access to health information and improve health equity for the members of the deaf community. I do want to emphasize the point that this is patient-centered care, patient-focused care, and it may be the first time that you meet a deaf person, you're unsure of how to engage. but take a moment to make sure that you approach them as a person, even if they communicate differently. Give them the same dignity, the same respect, the same autonomy, and the same concern for their health and ability to make decisions, as well as tools to make health-related decisions that impact them. They deserve the exact same expectations and respect that you would give to any of your patients. And autonomy, really, it's important to recognize that. They may go through a frustrating learning experience. It may be an experience for you learning how to communicate with deaf patients. So think about different ways that you can do that and working with those deaf patients. And there's so many different ways, that you can learn about communicating with deaf patients, making sure that they have an interpreter, providing information to them and to their family. And to you, it may not mean that much, but to them, it's going to have a huge impact on their current life as well as on their health outcomes for the future. So again, our goal, the message that we've tried to communicate from the very beginning, when we talked about the harmful assumptions, is the fact that each child deserves full language and communication access for healthy development, whether they're deaf or hearing. This is something that they deserve. And medical providers and colleagues and professionals who work in medical settings can join us in making sure that there is increased awareness about adverse childhood experiences related to communication, and then act to prevent the negative impacts that it can have on healthcare. And these are our colleagues who were an amazing group who contributed to the project from a variety of different universities that you can see here. They made this work possible. Oh, I'm sorry. Do you want to come up next? Yes.
Can you see me now? Okay, great. Yeah, we can both stay on the screen together if you'd like. Claire is a former student who worked in my lab, and she is, we continue to work together as she moves forward in her PhD. And we're also working with other colleagues to write this paper. So I want to acknowledge all of the people who co-authored this with us. Next slide. And if you'd like to contact me to talk more or collaborate, this is how you can do that. I do see a few questions in the chat, and I will pass that over to the moderator to manage those.
Thank you so much for sharing your research with us today. That was really an incredible presentation. So as we mentioned at this point, I'm going to open it up to Q&A from our audience, and we do have some questions in the Q&A. And for those of you in the audience, you can look at the bottom of your screen and click on the Q&A button to ask some questions, and we'll get through as many as we possibly can. So to get to some of the questions that are already in the Q&A, you did mention how toxic stress can really explain and contribute to physical health outcomes later in life. And we have a question about if you have any insights about what that causal link is between language deprivation and, for example, lung disease, one of the chronic diseases that you mentioned.
Yes, I'm happy to. The causal link, yes, I'm happy to talk about that. We didn't focus on the causal link specifically. We collected patient-reported outcomes, and we saw that in our research. And so I could talk about why we assume that link is happening. So for example, using the example of lung disease, that one came up in the context of mental health issues, in the context of communication neglect. So in that context, this group of individuals have a language, they know what they're missing, they know when they're missing something, they feel when they're missing something, and they experience things like anxiety and depression. Oftentimes, coping mechanisms for anxiety and depression is alcohol abuse, smoking. And so that is what we are speculating as what is happening. And that is secondary to the mental health issues that we are seeing as a coping mechanism. Yeah.
Thank you for that. We also mentioned how cochlear implants may play a role for deaf children earlier in life now that we do them quite early. And so we do have a question about the effect of early cochlear implants for deaf children. And has there been any research about whether this technology decreases the effects of ACCE?
We included data on hearing devices and how often they're being used, whether it be hearing aids or cochlear implants, and how much could be understood while they're wearing these devices. And then we looked at the correlation between the two. What we found is that there is no correlation between the technology and the use of technology and their health outcomes in ACCE. We do not see that connection. We do see the connection between their perception of the communication experience in the home. So a person who might use language growing up, they could perceive their home environment as not being accessible. A child who uses a cochlear implant maybe speaks really well, and that child could perceive that they do not have access to communication at home. That perception is what's important here. And that's what we intend by this patient-centered care approach that we are proposing. We're focusing on the person. We're asking the patient what their experience is. That's the heart of the patient-reported outcome approach. So we do recommend giving children sign language if they do want a listening device, if it benefits them, offer that to them. If spoken languages are something that they have access to, but access to communication is what's important rather than the technology or the device, but it has to be given with a signed language.
Yes, and if I may add to this comment about cochlear implants, I mean, they are wonderful devices. However, there is a huge variety of outcomes and connection with their function. For some deaf and hard of hearing children, they were able to attain levels of speech and develop that in some ways. For others, they are not. And those who don't, it tends to be several years of trying to wait and see if that cochlear implant and training is going to help them, because it takes time to train them on how to use it, how it's transmitted. It's not that the child has the implant and then automatically they're ready to go. They have to understand what different sounds mean, how to create speech sounds. So there's no reliable prediction of who will succeed and who will not succeed in developing an accessible language through this. So if you spent several years focusing on trying to give a child an implant and train them, and then if it doesn't work out, by that time, that deaf child is 5 or 6 years old. And so they've already spent 5 to 6 years of their life with no exposure to language. They're then now already language deprived. So waiting to see if that approach is going to work contributes to language deprivation. So that is the reason why we advocate for including sign language, and preventing a failure, so to speak, by giving them some form of language, because we know the effects of language deprivation.
So this is how those next steps you outline would be broadly applicable across the board, across the deaf community. I really appreciate that response. We do have a question about kind of reversing what we've talked about today, about if there's any traumas related to hearing children helping non-hearing parents and grandparents. The person who posed the question shared that their grandfather lost their hearing in middle age, and cousins had made efforts to include them in family discussions with middling results. But do you know of research that talks about hearing children and their role with non-hearing children and the effects perhaps on both?
Yeah, I can answer that one. I am experiencing that situation right now. My father spent most of his life as a hearing adult, and I can fully understand how frustrating it would be to then lose your hearing. And trying to include him into family conversations, and trying to get him to use a hearing aid, it is a very different type of loss that that person experiences. It is significant, it is psychological, and it is a tough experience to deal with that type of loss. And that experience is different from deaf children who are born deaf or become deaf early in life. It's quite different. It's a different sense of loss. If someone who became deaf early in life or was born deaf, they don't know what it feels like to be hearing. So they were born deaf or born deaf-blind. So they're used to that experience in that context. I myself have hearing children. I raised my 2 hearing sons, and that was my 2 hearing sons in the picture that I showed earlier. And like many other children of immigrant families, so those who have moved to the US and the parents are not familiar with the US, with English, and these children end up in a caretaking role for their parents, and many times they often grow up too fast. They find themselves in interpreting roles, similar to these hearing children of deaf parents who find themselves in those types of situations. That does often happen, I would say more in the past. Now that experience is less common because of the American with Disabilities Act. Now hospitals more and more, school systems more and more are providing accessible resources. Zoom has closed captions today. We have interpreters present. So that experience has not gone away. It certainly exists, but it has been mitigated. It is less frequent as opposed to how it used to be in the past.
Yes, and if I could briefly add to that, I would say it's so important in medical settings because sometimes children are asked, can you interpret for your deaf parents? And it's so critical that we not do that. That is not the appropriate way to address it. We need to bring in a professional interpreter and not put that child in that position.
And the other side is true. If the child is deaf or deafblind or hard of hearing, and they're a 12, 13-year-old child and they want to communicate with the doctor, they have the right to communicate directly with the doctor, not through the parent, right? You don't want to ask the parent to be the interpreter in a medical conversation. We want to make sure that we're respecting the patient in that way as well.
I really appreciate too, in that analogy too, with the, an interpreter from a different country. It's very salient. I think that's very helpful as well. We have a question about level ratings of stress across these studies. And I imagine that the ACCE is one type of this measure of stress, and there are different types of stress metrics. And so I'm just wondering if you can comment on those who report feeling excluded from communication opportunities and how they rate on various stress metrics compared to those without this feeling of communication exclusion.
We have data that is self-reported. So we didn't use the biological physical metrics. That would be very interesting. We do notice, however, that they are able to provide a rating. They're able to identify a range, but it's more about frequency. That's the range that they report on. The range that we gave them was never, rarely, sometimes, often, or always. And what we found is that people's experiences of ACEs are also similar as ACCEs. So people who say, sometimes this experience happens, you don't see a strong correlation with poor outcomes. And you see that in studies done on ACEs and ACCEs. If people report that they sometimes do experience these things on a negative basis, it's not enough to create the level of stress that would result in chronic health conditions. So for providers, I stress that you focus on people who are reporting these experiences as often or always.
It's very helpful. We have a lot of appreciation for the work that you've been sharing with us in both the chat and in the Q&A. So just again, we just really want to thank you for that. We have a question around policies. So one of our questions centers around the fact that they believe, governments should be involved in making sure that we have the right policies in place to deal with some of these barriers faced by deaf children and deaf adults as well. have you worked at all in this advocacy space with the U.S. government to think about specific policies that could take care of this group, that could support this group?
There's a huge group that includes the early hearing detection intervention organizations. There's a lot of people that are involved in that. Personally, I could, but there are a lot of people who are currently involved in that. So my focus is more on adults, older adults, caregivers, older adults with dementia and Alzheimer's. We just did a paper with a call to action policy in the Journal of Public Health reported. It was just published by the CDC. And so I'm focusing more right now on adults. But Claire, did you want to respond to that?
Yes, I completely agree with your comment. That policy, definitely we need more policies established to prevent this from occurring. There is an effort happening now that's called Lead K, and they work state by state on that effort to impact policies that have to do with language development outcomes for deaf children. Whether we're talking about spoken languages or sign language, they have to track the child's language development. And that policy looks a little bit different depending on the state. And I actually just moved to California. California is where Lead K was first established. And I'm actually in the process of learning more about how they apply and practice that personally here, focusing on the children of educable age population. So yes, there is ongoing effort, and it is definitely something that I hope one day we can establish to be a nationwide policy.
Wonderful, fantastic. And thank you to the audience for sharing your questions in the chat. And thank you again to our presenters. And I want to bring on Dr. Daryl Oakes to close us out today.
Wow, that was quite a presentation and just covers so many important topics that really brings new perspectives to these issues and these struggles. So thank you so much, Dr. Kushnalgar and Claire, and to the interpreters, Jolinda and Charette, for making this webinar, bringing it to us and bringing this information to us. My name is Daryl Oakes. I am an anesthesiologist and the Associate Dean for Postgraduate Medical Education here at Stanford. And I just, on behalf of the organizers for this lecture series, and that includes the Stanford Center for Continuing Medical Education, the Office for Faculty Development and Diversity, the Stanford Medicine REACH initiative, and that's the Racial Equity to Advance a Community of Health. I would just like to thank each of you in the audience for attending this webinar, and really hope you enjoyed the presentation today. And if you're a clinician and you're seeking to claim credit, CME credit for the webinar, please be on the lookout for an email that will come later today. It will have a link to an evaluation, and when you've completed the evaluation, you will be able to claim CME credits for participating in the program. We will also have a recording of this webinar available for you to review or for you to share with others. It's going to be available at the website healthequity.stanford.edu, and will be available in the coming weeks. So please go to the website to check it out. And thank you also to my CME, Stanford CME team, Kurt, Melissa, and Jayzona, as well as the course directors, Terrence and Magali, for all of their amazing work putting together this lecture series, helping feature and really important topics like the one we were able to cover today, as well as many other issues related to health equity in our healthcare systems, so that we can really better, as providers, provide equal opportunity and equal priority and for care, as well as the highest level of care to all of our patients. And if you're interested in more education that's focused on DEI and health equity, please check out other recorded webinars that we have on the website at healthequity.stanford.edu. And again, Stanford Medicine is really committed to featuring educational webinars on DEI, on health equity. So keep an eye out for our future programs on this topic. So thanks again for attending, and thank you again to our amazing panel. Really appreciate you providing us with this really wonderful session. So enjoy the rest of your day.